Okay, today we are going to be talking about the disorders of the immune system and the hematologic systems. We have a lot of material to cover. It's going to take about 2 hours, and it's a little bit more diverse. It's not one topic, it's a couple different subjects in there, so it should be able to keep your interest. Okay, so one of the most basic things that the human body can do is to protect itself from disease or an illness. So your immune system is job is to function as the body's defense mechanisms against invasion from any kind of a foreign substance. And the immune system allows for a rapid response so that we don't have any problems and maintains health of the person. So we have two parts of the immune response. First is a non-specific, and the second is a specific response. And we're going to take a look at all these individually. First, when we talk about a non-specific immune response, we talk about kind of our first line of defense. This is things like the skin itself. This is things like the acid in our stomach, maybe some of the oils on our skin that help to protect us from foreign organisms. Okay, the specific or adaptive response, or the second line of defense. We have two groups of cells, all part of the white blood cells, the leukocytes. We have the humoral response, which has to do with the B cells, and we have the cell-mediated response, which has to do with the T cells. When we are talking about the B cells, we are talking about fighting an invasion, fighting an attacker, fighting a foreign protein that is happening outside of the cell. And I want you to take a look down here at this picture. You see a little protein, a protein chain on that B cell. It looks like a little Y, and I want you to keep that in your mind as I am talking about how the B cells work. And then you see the T cell, and the T cells are taking care of infections that are happening inside the cell. And I want you to take a look at that MCH1 receptor that is on that T cell and kind of keep that in your mind also when we are moving through some of this material. Let's take a look at the mononuclear phagocytes. So the monocytes are produced in the bone marrow, and they circulate in the blood for a few hours, and then they differentiate. Some stay as monocytes, and others turn into phagocytes, and those phagocytes take themselves and they settle into the tissues, and they're kind of like an army waiting for somebody to invade. When something invades, when there is a foreign protein, an antigen that enters, the phagocytes jump into action. That means that they're like the little Pac-Men, and these little Pac-Men go around and they chomp down the foreign invader, they chew it up, and they process it, and they take a tiny little piece of that foreign protein that is in there that they have kind of stuffed inside the macrophage, and they post that little tiny piece of that foreign protein on their cell surface, so it's stuck on the outside of the phagocyte. And once that tiny piece of the foreign antibody is on the surface, that's when the lymphocytes, or the blood cells, can start to work and the immune response starts to kick in. Okay. So, the phagocyte has done its job. It has the first line of defense. It's the army on the front line army. It chomped down the organism. It chewed it up, put a little bit piece of the foreign protein on its cell wall, and now the white blood cells can do their job. Here we're talking about the lymphocytes. There are two types of lymphocytes, the B cells and the T cells. The B cells, they actually come from important to know, they come from the lymphoid stem cells. They are produced in the bone marrow. The B cells are part of the humoral response, which we're going to talk about in a couple minutes. And the T cells are produced in the bone marrow initially, and then they migrate to the thymus, which is in the chest, where they mature. And the T cells are divided into two different categories: the T helper cells, or the CD4, and the cytotoxic T cells, or the CD8. And we are going to, in just 1 minute, take a look at what the B cells do, the T helper cells, and the cytotoxic T cells, and what role they play in the immune response. Okay, let's talk about the B cells and the role of the humoral response for pathogens that enter the cell or enter the body and are remaining outside of the cell. So on the very first slide, I said, let's take a look at this B cell down there, and you saw a little receptor, a little Y, that is attached to the outside of the B cell. There are hundreds of thousands of these little Ys, these little proteins that are out there, and they're very specific to different invaders. And there's millions of different combinations. So what happens is something invades the body. Some sort of an antigen gets in there. And we have the macrophages doing the initial takedown. But then some of the organisms are in there floating around, and we have the B cells that are floating around. And as the B cells float around, and they all come by and they knock into the antigen, and eventually we will find the right B cell, and it will attach. It will take the antigen and it will attach it to that little Y receptor, like a lock and key. So they fit together. It's the exact right antigen to the exact right antibody, and they make a little connection. When they make that connection, they call that optimization, but it doesn't matter if you know that or not. The cell actually begins to differentiate once it's hooked up with the antigen. What does that mean? It differentiates into two things. First, it differentiates into memory cells. So in those, when we have memory cells, you know how they say you cannot get the same infection twice. And that's because you have this long-term immunity, because once that organism came in, you develop memory cells that last a very long time. And if it came back again, that same organism entered the body again, or that same foreign intruder entered again, we would have lots of B memory cells, and it wouldn't take us so long bumping around in there to try and find the right one. So we would fight it. The other thing it differentiates is into what they call effector cells. Effector cells, or plasma cells, is what you hear more often. And these plasma cells become antibody factories. And these plasma cells start making tons and tons and tons of antibodies and putting them out in the body. And then these antibodies are circulating around in there, and they're trying to find all of the antigens. So you have all these millions and millions of antibodies now, and they are grabbing a hold of all of the antigens. They're grabbing a hold of all of the things that are infecting us. And when they do, they become activated. And when they're activated, that means that they're tagged for pickup. Tagged for pickup means kind of like, now I have one antibody, and I've got, it's holding onto an antigen. And actually, each antibody can hold onto many antigens. And a couple things happen. It's tagged for pickup. It's activated. It's tagged for pickup. That means it's got like a red flag out saying, macrophages, come get me and get me out of the body. I have some of these invaders. And in addition to that, it does help for the spread of infection, because one antibody holds on to lots of antigens, which makes those antigens unable to do what they were doing before. It makes them very large, so it's very difficult for them to enter into my cells. Okay. Let's take a look at the cell-mediated immune response, when a pathogen makes its way inside the cell. Okay, so we have the T lymphocytes, which again are produced in the marrow and mature in the thymus. We have two different types of T lymphocytes. We have the T helper cells, also known as CD4 cells, and we have the cytotoxic T cells, or the CD8 cells. They are responsible for cells that have gotten, for infections that have gotten inside the cell. Things like intracellular viruses like AIDS, tumors, fungus. Okay, let's take a look at the T helper cells. What do the T helper cells do? Well, let's think back. Remember we said that the phagocyte initially finds the antigen. It's the first line of defense. It chews it up, it processes it, and it puts a little bit of the antigen out on its surface. What that antigen is for is to attract T helper cells, and which actually stick to the surface of the phagocyte, and then it becomes activated. So we had the first line of defense. We had those soldiers out there. The phagocyte chews it up, puts a little piece of the antigen on its surface. That antigen's job is to attract T helper cells. And when the T helper cell finds that phagocyte, it attaches to it. And when it attaches to it, it becomes activated, like so many things that we hear. It's able to exert its function. And when it is activated, it releases the cytokines. And you remember that we said cytokines are the cell mediators of the immune response. So very early on, some kind of crazy organism comes in. We have phagocytes to grab a hold of it, chew it up, process it, put a little antigen on the surface of their cell wall. T helper cells are attracted to that phagocyte that's already chomped down some of the invader. The T helper cell attaches to the phagocyte, and when the T helper cell attaches to this phagocyte, it produces cytokines, which are able to call and attract all of the other macrophages and all of the other B cells and say, here's where the infection is. So we also have, when we have that activated T cell, that T helper cell, because it's attached to the phagocyte, that cell differentiates. And what does that differentiate into? It differentiates into T helper memory cells, and they stick around for a long time. And it differentiates into effector cells, which replicate, and those effector cells, those T helper effector cells, become little cytokine factories, and they are releasing more and more and more cytokines. So that's something that should help that come full circle. When we talked about the cytokines before, we didn't necessarily give you a full understanding of how that happened. Now we're going to be talking about the cytotoxic lymphocytes, or the CD8 cells. What happens? Let's step back for a minute and say that every single cell in the body has a little receptor on it called an MHC1. So it has one little receptor which kind of tells you about the health of the cell, about the how the cell is doing. If a cell has been invaded by a virus, or has been invaded by a fungus, or has been invaded by a cancer cell, the receptor, the MHC receptor, changes a little bit, and it has a little bit of the foreign protein on that receptor. So every single nucleated cell in the body, that means every cell except for the red blood cell, has this MHC1 receptor. If something is wrong inside the cell, that receptor has changes done to it, and there's a little tiny piece of protein. And so we have these CD8 cells, and these CD8 cells are floating around, and these are cytotoxic cells, and their job is to float around and look for foreign material. And where are they looking for foreign material? They're looking for foreign material on the MHC receptor site. So they float around, And if they find this foreign material on the MHC receptor, they clamp onto it. When they clamp onto it, they become activated. And once it's activated, just like everything else, it divides into memory cells and it divides into effector cells. So the cells replicate and differentiate. When we have the memory cells, that's for long-term immunity, like if the cancer comes back. And we have these effector cells, which their job, they have clamped onto that cell. What they do is they inject a foreign substance or a cytotoxic, a cytotoxic substance into the cell. And when they inject that cytotoxic material into the cell, they alter the cell membrane and they cause the cell to disintegrate. It causes cell lysis. So that's why they call these the cytotoxic T cells, which is part of our immune system. All right, just a word about the cytokines. So now we know that the cytokines come from the CD4 cells, the T helper cells, and their job, we said when we talked about sepsis and ARDS, we said they are the cell mediators of the immune response, and they are. So we know that the immune response takes all kinds of communication and interaction between the T cells and the B cells and the monocytes and the neutrophils and the fibrin. We've talked about that. And so the cytokines are the messengers that act to send information back and forth and control how much of an immune response we have and all the activity. Okay, in this slide here, I just, for those that are visual learners, this is everything that I've just said, but we talk about the humoral response and the cellular response, or the humoral when something attacks us outside of the cells, the cellular response when something gets inside of our cells. And that's just kind of everything we've said in chart form. Again, what are they protecting against? Extracellular versus intracellular, and then the intracellular also looks at tumor cells as being part of what it protects against. Okay, just a quick word on what happens with the aging immune system. Well, with everything else, the aging immune system doesn't respond as well as it did when it was younger. So we have a decrease in our antibodies. The thymus gland becomes kind of old and not doing what it's supposed to do as well as it did when it was younger. So we know that that's where the T cells mature in there. So we have less T cells. We have a higher incidence of tumors, and we have a higher incidence of autoantibodies or antibodies against the self. All right, so that's going to help us segue into our next topic of autoimmune disorders. What's an autoimmune disorder? Well, we said that as the immune system ages, there is an increased incidence of autoantibodies. And normally, well, let me just start by saying, well, for some reason, and we're not really sure what that reason is, the immune cells that normally don't pay any attention to our own body cells become activated. So normally you can have a normal skin cell, you can have a normal kidney cell, normal liver cell, and the T cells, the B cells, they're all just floating around in there and they don't care. They're okay. They recognize them as self. And for some reason, with an autoimmune disorder, the T cells or the B cells or both B and T cells become activated and they are auto-sensitized. That means that they start to cause tissue damage. That means that they start to attack the self, attack their body. Now, the thing that's important to know about immune disorders is that they seem to cluster. That means that they don't just most people don't just have one autoimmune disease, they have multiple autoimmune immune disorders. And we're going to take a look at individual disorders and then how to treat them as a whole. Okay, so here's a list of the autoimmune disorders, also called rheumatic disorders, rheumatic diseases. Today we are not going to study all of these things. I am going to talk to you in general about what an autoimmune disorder is, and we are going to talk in general about how to care for people with an autoimmune disorder. Because when you are out practicing, there are many, many autoimmune disorders, and many we haven't even discovered, I'm sure. So when you look something up and you see that it says an autoimmune disorder, you'll know basically how to treat it. So here, take a look at this just as a general reference. We're going to take a minute and we're going to look at lupus. And lupus is very popular, very common disorder out there. What is lupus? Well, first of all, the etiology is unknown. Like with all autoimmune disorders, they believe that there is some sort of an underlying genetic predisposition, and then something happens which triggers this person's immune system to start attacking itself. Well, in lupus, what happens is there's some sort of genetic predisposition. There is some sort of a trigger. What is the trigger? In many instances, they believe the trigger is sunburn. In many of the autoimmune disorders, we keep these people out of the sun because the sun does seem to trigger the immune response. And when it triggers that immune response, it will put them, make the disorder worse, and or they were in remission and now it can exacerbate that. All right, let's talk about lupus specifically. Well, there are no real specific clinical manifestations to lupus. It is an autoimmune disorder that is directed at the DNA of different cells. What does that mean? That means that somehow the body becomes sensitized. The body starts to attack the DNA of certain cells. What cells does it attack in lupus? It is systemic. It can attack any cells. What cells does lupus like to attack most? It really loves the kidney, but it can attack the joints, the heart, the brain, and the lungs. So we have these cells, we have the immune system that starts to attack the DNA of certain cells. When it attacks the DNA of those cells, it causes cellular damage, and we have this over-exaggerated response by the B cells and the T cells, which are killing off the person's good tissue. Let's talk generally about clinical manifestations. Everybody is going to be different because if lupus is attacking my kidney, I'm going to have kidney symptoms. If lupus is attacking my lung, I'm going to have the pleuritic pain that they have. If lupus is attacking the skin, they have big rash, butterfly rash, discoid type of a rash. In general, you can say for most people with any autoimmune disorder, fatigue, myalgia, arthralgia, muscle pain and muscle and joint weakness and fatigue are very, very common. The body is working very hard at killing itself. So the body is using at rest is like it has an infection at all times. So it's always working really hard. One of the characteristic signs of lupus is a butterfly rash, a rash that is on the cheeks, across the nose, and onto the other cheek. Again, there you have it. Renal involvement is one of the common systems that it likes to attack. What's sclerodoma? Just to mention. Sclerodoma is, they call it hard skin. If you've ever seen someone with it, you won't forget it. The skin and the subcutaneous tissue becomes harder, more and more hard. It becomes more rigid, and you can't even pull it up from the underlying structure. So it is almost, it's very, very stiff. Very stiff. And if you see somebody, like the skin starts to pull taut because it gets so tight. You might use Google Images and take a look at what sclerodoma looks like. It's not that prevalent in terms of the prevalence in terms of the population. Fibromyalgia, you hear a lot about. It's on television. People getting medication. It's a condition of chronic pain with muscle weakness, achiness, fatigue. And they have there's 18 specific points that seem to hurt more. When we talk about these autoimmune disorders, we talk about, psoriasis. You can talk about Raynaud's disease. You can talk about Huntington's disease. So again, it doesn't matter what the cause, the nursing care is going to be relatively the same, and that's what we're going to talk about here. So the nursing care for the patient is very important. Assessment, we said that fatigue is a major problem, and muscle pain and weakness, joint pain and weakness. You can imagine, so our assessments will be geared towards pain, fatigue, weakness, maintaining self-care, coping strategies, self-image issues. Somebody with sclerodoma is looking very, very different than they did before. Psoriasis changes an image. Lupus with a rash across your face changes image. And so then our diagnoses, what main diagnoses are we going to have? Fatigue related to the inflammatory process, acute or chronic pain, self-care deficits, disturbed body image and coping, and ineffective self-health management. That all goes to following the therapeutic regime. So what are we going to do? What are we going to plan? For these people, we are planning to provide the medications that we need so that there is no pain. We want to make sure that with no pain, we can improve their sleep. With relief of pain, maybe and providing some sleep, that will help with the fatigue during the day. We are concerned about improving body image and developing effective ways to cope. So, how are we going to slow the disease progression? We are going to be giving immunosuppressives to these people. So, people with autoimmune disorders typically receive immunosuppressants. What kind? Well, Plaquenil is what we use as one of the first lines of defense for people with lupus. We can use other immunosuppressive like the anti-rejection drugs like Imuron and Cell-Cept might be some of them. We might give certain people, certain illnesses, we might give them the new biologics so that it is an immune response. What is that immunosuppressant supposed to do? It is supposed to suppress the immune system so that the body's own immune system stops attacking its own cells. In terms of medication, we often give medications to control the pain. Things like NSAIDs, DMARDs. We can use heat and cold. We are always concerned about nutrition because people with autoimmune problems do have an increased need for calories, not too much. We don't want an overweight problem. But if I have rheumatoid arthritis and it's hard for my hands to work and it's hard for me to move and it's hard for me to get to the refrigerator, then I might not be eating, and nutrition then becomes an issue. Self-care. Things to facilitate self-care, whether it be adaptive devices, they make special things to wash. They make special toothbrushes with special handles, spoons and forks and knives and bowls to help with any debilitation in that regard. So that's some of the things that we are going to do for somebody with an autoimmune disorder. So we talked about an autoimmune problem, which is kind of like an exaggerated, out of control immune system that is attacking itself. That's one end of the spectrum. And the other end of the spectrum is immunodeficiencies, when the immune system is inadequate, where there is an actual immune system because there's a problem with our first line of defense of phagocytosis, the humoral response or the B cell mediated response, the cell mediated response or the T cells, or a combination of all three of those. So, we can have a primary or a secondary autoimmune deficiency or immunodeficient state. And primary is what we talked about, with a problem with some of the actual cells, or a secondary immunodeficient state would be from a drug-induced immunosuppression, whether it be chemotherapy or immunosuppressants that we're giving the person. Those that are very young and very old, certainly malnutrition, radiation can put people under the weather. If we've had to have surgical removal of some of the important glands, like our lymph glands, thymus, or spleen, and then some of the lymphomas that put us at risk for immunodeficiencies. Certainly, one of the biggest immunodeficiencies that we talk about is HIV. And that's a big problem in the world, in the United States, but also in the world. The CDC estimates that 1 million people in the United States have AIDS. In 2010, there were 60,000 new cases. Every 9.5 minutes, they say someone is infected with the AIDS virus, and more than 21% of the people who have AIDS don't know that they do. In the world, it kills 2 million people each year. Now, we have had advances with the antiretroviral therapy, and people are living a lot longer, and it's not until the very, very end of the disease process that they are really suffering. So today we are going to talk about HIV and some of the infections related to HIV. So it is an infectious disease. It's transmitted via the blood, seminal fluid, vaginal secretions, amniotic fluid, breast milk. It is not transmitted through casual contact. Like all viruses, it is an intracellular parasite. Once it gets into the cell becomes like a virus factory for it. So what's special about AIDS, HIV, not AIDS, is it belongs to a group of viruses known as antiretroviral, or not known as retroviral. So that means that it is an RNA material instead of a DNA material. HIV targets the CD4 cells or the T helper cells. Let's have a word about HIV versus AIDS. HIV is the virus that infects us, or people. When you are infected with the virus, you are HIV positive. That means you have HIV antibodies. That means that you have HIV floating around in there. When you convert from HIV to AIDS, you have a set of symptoms that you're going to talk about. You have an opportunistic infection. You have a low CD4 count and an opportunistic infection. So people with AIDS have HIV. People with HIV do not necessarily have AIDS. Okay. Let's talk about the categories of HIV. We have that primary infection, the acute infection. When the HIV virus is introduced into the body. So somebody was an IV drug user with a dirty needle. There was a needle stick. There was unprotected sex. So the HIV virus enters the body, and like all viruses, it targets specific cells. With HIV, it targets the CD4 cells or the T helper cells. Most people have a CD4 count depends on the source you're looking at, between 700 and 1,000 or 800 and 1,200. So what happens? The virus comes in, it seeks out and attaches itself to an uninfected CD4 cell. So it attaches itself to a T helper cell. When it attaches itself to a T helper cell, it injects its viral core inside the host cell. And then that cell becomes a virus factory, producing all kinds of HIV virus and releasing that. And more cells become infected. So it takes about 3 weeks for enough cells to get infected that the person actually gets, in the initial phase, what seems to be like a flu. And that's what they think it is. That's why people don't know that they're infected. Seems to be like a flu, kind of like a mono. And it takes a couple weeks for the body to recuperate. How does it recuperate? Well, the HIV virus is inside the CD4 cells, certain CD4 cells, and those CD4 cells are making a virus and putting it out there. But after the initial insult, when the initial flu-like symptoms, the rest of the immune system starts to do a pretty good job. So you see the B cells doing what they're supposed to be doing, trying to get rid of any HIV that's not inside the cell. You see the T helper cells doing their job, trying to make cytokines. You have the cytotoxic T8 cells that are trying to attach to these infected cells. So a CD4 cell that's infected, we know because it's infected, the MHC1 receptor site will change. It'll have a little bit of foreign protein on there. So the good CD8 cells are flying over there, attaching to that, and they are injecting their cytotoxic material in there so that they will self-destruct. And the balance between the amount of HIV in the body and the body's immune system is referred to as the viral set point. Kind of like, okay, there's the virus is in there, it's doing their thing, but the body's immune system is also doing its thing. So what results in kind of like a nice balance between infection and immune response is that there's like a steady state of infection. And that steady state of infection is kind of how people live, usually for 8 to 10 years, untreated for 8 to 10 years. So it's not for a long time before we start to see signs and symptoms of infection. Okay, so we have that early chronic infection, where we have the low viral load. The CD4 count is greater than 500. The person is asymptomatic, and it can last for 8 to 10 years untreated. Then we move into the time period where we call it intermediate chronic infection, where CD4 counts start to drop. They're between 2 and 500. The viral load begins to increase. And the viral load begins to increase, and that means that the immune system is beginning to fail. The virus is getting the best of the immune system. That's when the person becomes symptomatic, and we see fever develop, headache, fatigues, maybe the yeast infections is common. So it is not considered to be AIDS yet. It is just a chronic infection. They're making their way towards that AIDS diagnosis. Okay, the late or chronic infection, also referred to as AIDS, the CD4 count must be this. These categories are outlined by the CDC. So the person who has AIDS has a CD4 count less than 200, and they have one of the other opportunistic infections or cancers. So let's talk about what some of these things are. So I have a CD4 count less than 200, and I have an opportunistic infection, or I have encephalopathy or wasting syndrome. And one of the first opportunistic infections we're going to talk about is pneumocystic pneumonia. And specifically, PJP is how you'll see it. Jurovecki, pneumocystic jurovecki. It's the most common opportunistic infection, and 80% of the people will develop it if it's not treated prophylactically. Okay, so what is it? It is a pneumonia. And the pneumonia is caused by this PCP, and it is treated like any other pneumonia. It is contagious. It's very contagious to these HIV patients. Another opportunistic infection, tuberculosis. We are going to talk about tuberculosis a little more, where the PCP, I'm going to say we treat it like pneumonia, so we're going to treat it with antibiotics. We're going to treat it with bronchodilators. We're going to treat it with corticosteroids. We're going to treat it with oxygen support. So obviously it's going to be much more difficult to treat in these patients because they don't have a good immune system. Let's talk about tuberculosis. Okay. TB is an infectious disease that is one of the opportunistic infections for AIDS. It primarily affects the lung, but you can have miliary disease, and it can affect all body systems. Let's talk about how it works. How do we get it? Well, it is an acid-fast bacilli. It is spread through droplet spray. So that means when I cough, that means when I talk, that means when I yawn, that means when I'm breathing, I have some droplet spray. So this acid-fast bacillus, through droplet spray, someone coughs, I walk past, I breathe it in, that TB molecule or that TB organism makes its way down into my lungs, usually in the top part of my lungs. And in the top part of my lungs, I have a nice local immune response. Those macrophages are doing their job. They are running in there, they are chewing it up, and they are putting the antigen, the protein, on their cell membrane so that the T helper cells can come help out later on. And once inside the macrophage, what happens is these bacilli start to multiply in there. And they multiply and multiply and multiply because they're inside the cell. And a couple of them get out, and then some more macrophages come and try to eat those up. And what I have is all these macrophages coming together and making a big clump in there. And that big clump of macrophages that have TB in there that's multiplying and multiplying, we call that a tuberculoma or a granuloma, which is what you'll see like when you read an x-ray, a chest x-ray. You'll see that there's a granuloma, a tuberculoma in there. Again, that's just a clump of macrophages from the normal inflammatory process. And normally what happens, in 90% of the people, we breathe in this Mycobacterium tuberculosis. It goes in, we have macrophages, I get a little granuloma, and it's kind of self-contained, and that's where it is. We have a latent infection. That means that it's in there, the TB is in there, but it's all contained in that granuloma. In 5% of the cases, at some point later in life, that infection will reveal itself. When host immunity is down, when they're getting chemotherapy, when they've had a transplant, when they have HIV. So you have the initial infection, then the latent stage, and then it might turn into a full-blown infection because that infection kind of returns when they are immunocompromised. That's like only 5% of the people that'll happen to. Another 5% of the people never make their way to that latent stage of infection, so it's never self-contained. It kind of is a very progressive form, so they might be immunocompromised right from the very beginning. So they have a local progression, so they can get just a TB pneumonia, so that their lung is sick and it's all through the lung and we can treat that. Or they might get what they call miliary TB, or a very progressive form where the tuberculosis disseminates and it's in the lungs and the liver, maybe the brain and the kidney. So that's very, very bad, and probably person's very susceptible to death. Signs and symptoms. Well, a low-grade fever, night sweats, and a cough that starts to become that's more and more frequent. And at first, it's kind of like a white, frothy sputum. And then eventually, as the condition goes on, it is hemoptysis. So there's blood-tinged sputum. So general fatigue, malaise, anorexia sounds like any kind of flu. Night sweats, low-grade fever, a progressive cough, progressing. Some pleuritic pain, chest pain in there can come. Kind of very non-specific. Let's talk about diagnosing it. A PPD, we all get PPDs. To test to see if we have had a reaction to the TB, like do we have a latent infection? Is it hiding in there? A chest x-ray will show the tuberculoma or the granuloma. If we're very concerned, we will have a sputum smear and cultures. And a new test, the TB Gold, the quantiferon, the TB Gold test. It's the newest test recommended by, and we don't see it used just yet that often. It's the newest test recommended by the Center for Disease Control to replace the tuberculin skin test. They do the little tine test, the little 4 prongs that they can stab into your arm as like a little screening with antigen on there. But this is a test that will detect interferon gamma produced by the white blood cells in a patient with TB. The results are back in 24 hours. So this is really important when we are testing somebody. And of course, the definitive, the sputum smear and culture. Drug therapy. Well, we have a whole line of drugs outlined by the CDC. So there is a new drug-resistant strain of tuberculosis, so what's really important is compliance. So who gets primary resistance to one of the first-line drugs in people who had no previous reaction? All right, so that means, we're concerned about this drug-resistant strain. There is those people who have had no drugs and all of a sudden they have a resistant strain. There is secondary or acquired, and that is resistance to one or more drugs for a patient that has ongoing therapy. And that means that it was working for you and now it's not, that your organism has become resistant to it. And the worst, the multi-drug resistance, is resistance to 2 drugs, the INH and the rifampin. There's drug regimes that have been, regimens that have been set up by the CDC and how long they last, and they're combinations of drugs. And I'm going to say that INH and rifampin, just knowing that they're using anywhere from 2 to 4 drugs in the initial phase, and then up to 31 weeks later that you're still taking medicine of INH and rifampin. And the problem here is drug compliance becomes an issue, and people not taking, because they're going to be taking these drugs for 6 to 9 months. Some things that we have to think about. Vitamin D we give with INH to prevent peripheral neuropathy. Noncompliance is the major reason for drug resistance, and DOT is recommended, direct observation therapy. We take the meds on an empty stomach. We've got to, when we're taking INH, we've got to avoid foods that are high in tyramine and histamine. So that's your things like tuna and smoked foods, aged cheese. How do we know the person's tuberculosis is gone? We know that tuberculosis is gone if the patient has 3 negative sputum smears. That means it's not growing any TB anymore. Okay. So pneumocystic pneumonia is an opportunistic infection for a person with AIDS. TB is an opportunistic infection for somebody with AIDS. Yeast infection, candidiasis, in the mouth. What is it? It's like almost all patients will get a yeast infection. It is opportunistic. It's these like creamy white patches. It's very painful. It can be in their mouth and their gums. It can be they can have all the way down their throat, retrosternal pain. It can be ulcerating. Excuse me, they're at risk for it disseminating into other body parts. Chronic diarrhea. 50 to 90% of all patients will have this chronic diarrhea, which is very debilitating to lifestyle. Chronic diarrhea as a result of what the HIV virus does to the lining of the intestine. So we will do stool cultures lots of times, the Cryptosporidium, Salmonella, C. diff, that's all in there. Wasting syndrome. Wasting syndrome is very diagnostic. It says profound weight loss, involuntary weight loss, malnutrition, and a hypermetabolic state. We are talking about weight loss exceeding 10% of the baseline within 30 days associated with diarrhea and fever. They need to have an excessive number of calories because they are burning lean body mass. Just like in sepsis and burns and all, they are in a hypermetabolic state. That's to say that there's a distinction between this wasting syndrome and just cachexia and malnutrition. In wasting syndrome, it doesn't matter how much nutritional support they have. There is an increased protein metabolism in relation to fat metabolism, which results in significant loss. So like we talked about, because we have this increase in this hypermetabolic state, we talked about when we have a hypermetabolic state, we have an increase in cortisol. That cortisol causes protein catabolism, so it's breaking it down, and so we're losing lean muscle mass, and the person is diagnosed with this wasting syndrome. Diagnostic of AIDS is a CD4 count less than 200, and HIV encephalopathy or HIV associated dementia, HAD, formerly called AIDS dementia. That will get you a diagnosis of AIDS. It's it's just like dementia. It's a progressive decline in your cognitive ability, your behavioral, social skills, and your motor function. Cytomegalovirus. Cytomegalovirus is something that it was a little more prevalent than it is now that we have the antiretrovirals. It used to result in blindness, and it still can happen, but not as often. Of course, we already mentioned tuberculosis and syphilis as as a potential opportunistic infection. Some of the things that we see oncologically is the development of Kaposi sarcoma. That is a malignancy that involves the endothelium of the blood vessels and the lymph system. They get these little cutaneous lesions, these little darkish, purplish black marks all over the body. And they can be flat or they can be raised. Lymphomas are a common problem with people with AIDS. They have an AIDS-related non-Hodgkin's lymphoma, which we'll talk about in a little bit. Let's talk about antiretroviral drug therapy. What we do know is that the drugs, the ART, as recommended by the CDC, the person should be on 3 agents from 2 different classifications, and the rationale for this is to help prevent drug resistance. We follow the CDC has a very clear prescription, if you will, for the frequency and the dosing of these medications. So it's there is dosing guidelines from the CDC. It is recommended that women should receive antiretroviral therapy regardless of pregnancy status. And it's important for you to remember that even when the viral loads are below detectable amounts, they are still considered, the person is still considered to be infected. So then you ask yourself, I've given this person 3 agents from 2 different classifications. I followed the CDC dosing guidelines. I have discussed with my patient the potential side effects. I have discussed with my patient the dosing schedule. We have discussed how to incorporate these medications into your daily life and work schedules. And once all of that has been done, my patient starts on these therapies. I've discussed with them that they have to continue to take it. They have to take it at the prescribed time and in the prescribed dosage, and they can't just stop in the middle. Then I ask myself, how do I know my treatment has been effective? How do I know that these drugs are working for this patient? Well, I know that when I have a decreased viral load. Sometimes the viral load can even be undetectable. So, when the viral load is down, the CD4 counts are high. In other words, the person's immune system is keeping the virus in check. So the CD4 counts are high, giving you an indication of the health of the person's immune system and the immune response, and the viral load is low. I also to tell myself my treatment has been effective when the signs and symptoms, the onset of AIDS is delayed. Okay, collaborative care. Other things that you're going to teach your patient. It is really important that we have vaccinations. Hep B, flu, pneumovax are paramount importance for these types of patients. Let's talk about nursing assessment. Well, we said in the beginning that we could have 8 to 10 years where the patient is asymptomatic. So for 8 to 10 years, we might see nothing. But what kinds of symptoms are we looking for? Well, very early on, post-exposure, a couple weeks after exposure, about 2 to 3 weeks after exposure, I could be looking for flu-like symptoms. Remember, flu-like symptoms when viral load is high and CD4 count is low until the person's immune system is able to recuperate, and then it'll keep the viral load low and CD4 counts will begin to come back up. So let's talk about symptoms. We can talk about that we're looking to indicate that maybe this person is moving into that intermediate or late chronic phase. When we talk about extreme fatigue, loss of appetite or unexplained weight loss, swollen glands, muscle pain and weakness, a fever for more than a week, night sweats, unexplained diarrhea, a dry cough, which might be the precipitating event to the PCP, white patchy plaques in the mouth, indicating that they might have candidiasis, a yeast infection in the mouth. Painful blisters. People, lots of patients in the later stages have an underlying get a shingles. They have shingles. They had chickenpox when they were a child, and then the herpes zoster virus resurfaces as blisters. They could have the painless purple or blue lesions that we talked about on the skin when we talked about Kaposi sarcoma, right? Sarcoma of the endothelium of the vessels, resulting in those purplish blackish spots on the skin. Confusion or disorientation, indicating that maybe HIV encephalopathy is around the corner. And any kind of a recurrent yeast infection. We're looking for signs and symptoms of the opportunistic infections, particularly. We're looking for that pneumocystic carny, Kaposi sarcoma. We're looking for the culturing the diarrhea for cryptosporidius, CMV, cytomegalovirus. What would give me some signs and symptoms of cytomegalovirus? It looks very much like mono, where there's fever, malaise, weight loss. They might have positive cultures in the blood, urine, and throat. We're looking for signs and symptoms of tuberculosis, being perhaps a cough, fever, night sweats, flu-like symptoms. So we are looking for any of these symptoms that would indicate that the person's not feeling well, or that the symptoms of the AIDS virus are moving from the early stage to the chronic or intermediate stage. Let's think about nursing diagnoses. What types of things are we going to use? Well, nursing diagnosis here is great. It could be just about anything. Let's just run down some quick ideas. Certainly infection is a big problem. And so you'd have risk for infection related to nutrition. We talked about that wasting syndrome. So altered tissue, or what is it? Imbalanced nutrition, less than body requirements related to. We could have, thinking about pneumonia, we could have ineffective breathing patterns. We could have altered gas exchange. We certainly have fatigue. We might have, in the late stages, a self-care deficit. We might have coping problems. So what do we do about it in terms of implementation? Basic good nursing care. When we're talking about pneumonia, we're treating the pneumonia and all the things that we would do in terms of sitting the patient up, keeping them well hydrated, keeping the oxygen on, providing the antibiotics. Mucolytics are always nice. Guafenicin to have on board to make sure that we have those secretions thin, suctioning if necessary. Nutritional support for these people because they do have weight loss. We are talking about monitoring for fluid and electrolytes. When we talk about somebody, 80 to 90% of the people with a chronic diarrhea, we're talking about electrolyte imbalances. So we're talking about offering nutritional supplements like Ensure, and along those lines, we're talking about small, frequent meals, maybe seeing a dietitian. We're looking for skin breakdown when someone has diarrhea like that. We're looking to make sure that the patient, if they are getting confused, all the things that we do for other demented patients, we're looking to make sure that we can care for them. Safety, yellow socks to make sure that they don't fall. Okay. When we talk about health promotion and teaching, we talk about prevention of the virus from the very get-go. But after the person is infected, then we are talking about preventing the spread of infection to others. So in your textbook, I'm not going to spend the time here, but in your textbook, there are several pages that you can take a look at, which are talking about ways that you teach your patients, particularly to avoid sexual contact and spread of AIDS through sex. So we're talking about the proper use of condom, the proper use of a female condom. That is in your textbook, and you can take a look at that. Now, just one little comment about exposure. Exposure to you as a healthcare worker and post-exposure prophylaxis. So what happens? So let's just say you sustain a puncture injury, such as a needle stick. What do you do immediately? You wash the area thoroughly with soap and water. First of all, you should have had gloves on. Even if you got stuck, you should have had gloves on to, as a secondary barrier, to wipe some of the virus off, maybe as it moved through the plastic glove or the rubber glove. So take the gloves off, wash it thoroughly with soap and water. Get a hold of your supervisor, because there is a company policy about what you're supposed to do. What do we need to do? In some states, there needs to be certain permissions, but for the most part, we need to find out what the status of the patient is. What is their HIV, Hep B, and Hep C policies? You need to get to employee health as soon as you can. Get it all documented. They're certainly going to do some baseline testing for you for HIV, hepatitis B, Hep C. They can do that up to 72 hours, but they want to do it as soon as they can get consent from the patient to do that testing, as well as you. You want to get post-exposure prophylaxis. The CDC has guidelines that say start prophylactic medication within 2 hours of the exposure, and then take it for a total of 4 weeks. And you're going to follow up in 1 month, 3 months, and 6 months, and hope for the best. So the best thing that we can do is no recapping of needles, and please use the safety needles at all times. Okay. All right, let's shift gears a little bit. We're going to talk about the hematologic system. And so what is it? What is the hematologic system? That is all the blood and all the spots that it's made. The blood is considered an organ but it exists in a fluid state. When the body needs more blood, like if we need neutrophils to fight infection, or we need RBCs, or we need platelets, we increase bone marrow production. And bone marrow is what makes the blood. The bone marrow is located in the long bones. The bone marrow is the site for hematopoiesis. What's that mean? That means that the bone marrow is the site for blood making. And our production varies based on need. In children, blood is formed in all of the skeletal bones. In adults, it's usually limited to the pelvis, the ribs, the vertebrae, and the sternum. However, if we need more, we can develop it in some of the skeletal bones. It's highly vascular. It contains stem cells which self-replicate. So what does that mean? That means that the stem cells differentiate into two different types of cells. They can be the myeloid or the lymphoid cells. The myeloid stem cells differentiate into the erythrocytes, the leukocytes, and the platelets. In other words, the red blood cells, the white blood cells, and the platelets come from the myeloid stem cells. The lymphoid stem cells differentiate into T cells and B cells, and we know that there are the T helper cells, the CD4, and the cytotoxic T cells, or the CD8. Okay, so the erythrocyte, the red blood cells. The red blood cell lives 120 days. You know that's important, especially you knew that because of the hemoglobin A1C when we were talking about diabetes. Okay, so the erythrocyte consists primarily of hemoglobin, which contains iron. The presence of a large amount of hemoglobin enables the red blood cells to carry out its main job. And the main job of the red blood cell is to transport oxygen. So there we have it. It carries oxygen to the tissues. It picks up a hydrogen, a byproduct of cell metabolism, at the tissues that buffers the excess acid. Okay. So the red blood cells primarily consist of hemoglobin, and that's good. It makes up 95% of the cell's mass, and the job of that red blood cell, the hemoglobin, is to transport oxygen to the tissues. All right, let's talk about erythropoiesis. How do we make the red blood cell? Okay, so erythroblasts are immature erythrocytes, immature red blood cells. So what happens to them? These immature erythroblasts differentiate and they mature into the red blood cell. They start to accumulate hemoglobin. So the erythroblast starts to gather hemoglobin, and we remember that 95% of the cell mass of a red blood cell is hemoglobin. So these erythrocytes or erythroblasts begin to gather hemoglobin. When they get enough hemoglobin, the nucleus begins to die. They begin to lose their nucleus, and thus becoming one of the only unnucleated cell in the body. And that is the red blood cell. Now, differentiation of the erythroblast is stimulated by erythropoietin. You remember erythropoietin. So in other words, for that erythroblast to turn into an erythrocyte, into a red blood cell, it needs to have erythropoietin, and that comes from the kidney. And the kidney, you remember when we have chronic renal failure, the kidney doesn't make erythropoietin, and consequently chronic kidney patients are anemic. So the erythropoietin is made by the kidney. It takes about 5 days to help that erythroblast create an erythrocyte, or a red blood cell. Now, so we talked about how the red blood cell is made. Let's talk about how we get rid of it. So an old or an aged, they live about 120 days, erythrocyte starts to lose its elasticity. And when it loses its elasticity, it gets trapped into the small little blood vessels, and it gets trapped in the small little blood vessels, and in the liver and the spleen, they are able to filter it out. So when they filter out the red blood cells, as they die, they release their hemoglobin. So most of the hemoglobin that's in there is recycled, but there is a small amount that gets broken down and that gets secreted in the bile. The last little comment on there is about the erythrocyte production, red blood cell production. It comes from the erythroblast. It needs the erythropoietin. In addition to that, it needs iron, vitamin B12, folic acid, B6, and protein. Okay, the leukocyte, or the white blood cell. It comes in 2 different categories. These are important because we're going to be talking about cancers, lymphoma and leukemia. That's why we're looking at each one of the cells individually, where they're made and how they're made, so then we understand all of the leukemias and lymphomas. So the leukocyte, WBC, is divided into 2 main categories, the granulocytes and the agranulocytes. The white blood cell can live for days to years, so it's a lot more long living than the erythrocyte, or the red blood cell. A normal white blood cell count is 5 to 10,000. Granulocytes. When we talk about granulocytes, we talk about neutrophils, basophils, and eosinophils. We're going to look at them each individually. Let's look at the neutrophil. The neutrophils are the most numerous cells of this type. So they are components of the white blood cell, and the neutrophils will be the ones that are most in number. Fully mature neutrophils come from myeloid stem cells, and specifically from the myeloid blast cells. Why is that important? It's important when we're talking about leukemia. It takes about 10 days to make a neutrophil. They live for only 1 to 2 days. And important for you to know is immature neutrophils are called bands. So this is important for you when you are looking at blood work and you are looking and you're trying to look at a CBC and you're trying to read it and you're trying to decide what's going on with the person. When there are a lot of bands, you know that there are a lot of immature neutrophils in there. And that's, again, important when we're talking about cancer, which we will be in a couple minutes. What about the basophils? These are the least numerous. They release heparin and histamine in response to exposure to allergens. Oh, wait, didn't we already learn that? We said when there is an allergen or when there is an invader or an antigen, like when the body thinks that it has sepsis or when the body has an infection, the basophils release histamine, and histamine changes the permeability of the vessels. I'm hoping that this is all coming together for you because we've talked about all of these, and this is kind of filling in some of the gaps that we didn't have before. Okay, the eosinophils. Eosinophils are high when a person has a parasitic or an allergic reaction. So, the number of circulating granulocytes found in healthy people is relatively constant. Decreased elevation in the total number of white blood cells may indicate an infection or trauma or a side effect of corticosteroids, and a decrease in these values may indicate that they have a viral infection or they're on those antiviral medications, or in the worst case scenario that they have leukemia, which is what we're going to study in a couple minutes. Agranulocytes, leukocytes with granular-free cytoplasm. They are the monocytes and the lymphocytes. The monocytes are very active in the spleen and the liver, the peritoneum, the alveoli, and they differentiate in the tissues and they function as macrophages. We saw that, remember, when we were talking about the normal immune response. We saw that the monocytes were the ones who differentiate and have the macrophages, and the macrophages is one of the first lines of defense when we're having an immune reaction. The macrophages can live for several months. And then the lymphocytes, another granular-free cytoplasmic cell. We have the B lymphocytes that come from the marrow. We have the T cells that are produced in the marrow and mature in the thymus. And we remember that these T cells are T helper and the cytotoxic CD4 and CD8 cells, and they're really important in the immune response. Leukocytes protect the body from invasion of bacteria and other foreign entities. Platelets and thrombocytes. Platelets live about 7 to 10 days. They're regulated by thrombopoietin. They are essential, obviously, for the control of bleeding, and they have a lot to do with activating the coagulation factors. When we have a vascular injury, platelets can collect at the site and become activated. We talked about that. They adhere to the site of the injury, and then they kind of make a platelet plug, and they stop the bleeding. And then the platelet granules activate all the coagulation factors to keep a little blood clot there. anemia. It's classified by its etiology. So we have anemia that comes from a hypoproliferative disorder. So that means that the marrow cannot make enough red blood cells. So anemia, because we don't have enough red blood cells. Oh, you might say hypoproliferative anemia, that would come from someone with chronic renal disease because they don't have enough erythropoietin. It comes from, we said we had to have iron, B12, B6, folate in order to make erythrocytes. So if we don't have enough of that, we might have a hyperproliferative anemia. This is also where we put that aplastic anemia. I believe you discussed it last year in the freshman year, but this is an autoimmune anemia. We can certainly have bleeding because we simply do not have. We have hypovolemia. We simply don't have enough red blood cells. That can cause an anemia. And we could have hemolysis or hemolytic anemia because we have a destruction of the red blood cells. So what do we have? An autoimmune problem. An autoimmune problem being like where the body is attacking. So when I say autoimmune, the body's own immune system is attacking itself. And in this case, with an autoimmune anemia, we have premature destruction of the red blood cells, which results in freeing the hemoglobin from the erythrocyte, and it's now floating around in the plasma. And that destruction leads to tissue hypoxia because that the primary job of the red blood cell is to transport oxygen to the tissues. So if we have premature destruction of the red blood cell, we have all this free hemoglobin, but we don't have the hemoglobin being circulated to the tissues, so I have tissue hypoxia. And all that all that hemoglobin that builds up in the plasma has to be destroyed and removed from the plasma, and so we have increased bilirubin levels. And then we also have the hemolytic anemia, thalassemias, which is again an autoimmune problem. It's a group, like they group all these autoimmune problems into one. It is an inherited autoimmune problem, and it is a hemolytic anemia. So autoimmune, thalassemias, same thing. They come from early destruction of the red blood cell. Nursing care of the patient with anemia. First, in terms of medical management, we want to correct or control the underlying cause, get that taken care of. Then we talk about assessment. Let's just give you just a quick assessment. Certainly we want to do some blood work. H&H, we want to know RBCs, iron, folate, B12. We want to look at all of those things to determine what is the underlying cause. In general, because we're talking about an oxygen transport problem with anemia, we're looking for weakness and fatigue, maybe even some dizziness. Neurologically, we're looking for maybe numbness and tingling. They call that paresthesia. Irritability. Again, weakness, headache. They might be confused. Maybe some gait disturbances. Maybe even some abnormal reflexes. Some spasticity. Integumentary system. You might think that they would be pale. Their mucous membranes might be pale. You might even see a little jaundice, especially with a hemolytic anemia, because they are breaking down. They are breaking down all of those RBCs. Their nails might be brittle. You might actually see a concave nail because of or nails with big ridges in it because of the lack of the oxygen transport. You would expect that there would be delayed wound healing. You might see thin or gray hair, dry skin, maybe some sores in the mouth. Um, Person might have, in terms of cardiovascular status, palpitations, chest pain, tachycardia, hypotension. You would expect all of those because there's poor oxygen, so we have to have some compensation. You might see orthopnea or tachypnea. With the GI tract, there might be anorexia, nausea, or vomiting because of lack of perfusion to the gut. Maybe abdominal pain could be even resulting in maybe hepatosplenomegalia because of the increase in the breakdown. So, what's the goals? In general, what do we say? We want to manage the fatigue. How do you manage the fatigue? Prioritize the activities, balance rest versus exercise, prevent deconditioning. So you're doing passive or active range of motion, light exercising, maintaining adequate nutrition. You know, you want to make sure there's supplements, maybe small frequent meals, especially if there's some tachypnea. And certainly maintaining adequate tissue perfusion. So it might result in a blood transfusion to increase the amount of cells that we're having, or even IV fluids. Certainly supplemental oxygen would help in that regard. Okay. So let's talk about leukemia. Leukemia is really a group of disorders that a group of malignancies that affect the blood, the bone marrow, the lymph, and even the spleen. So it affects all the entire blood forming system. So one of the most common features of leukemia is that there is an unregulated proliferation of leukocytes in the bone marrow. What does that mean? Unregulated proliferation of leukocytes in the bone marrow. So that means that the leukocytes just go wild. Usually it is the neutrophil or the lymphocytes that are just reproducing, replicating. And then the bone marrow becomes completely packed with these immature cells, immature neutrophils, immature lymphocytes. And it does two things. One, it spills out into general circulation. Now we have all these immature cells out there that are unable to fight infection. And in addition to that, it crowds out all the other cells, all the other inside the bone marrow. So let's just say we have the neutrophils are going wild. The neutrophils are producing, and there's tons and tons and tons of immature neutrophils in there. And they crowd out and smush out all of the other cells. So we spill immature neutrophils, and we have a decrease in the number of other cells that are in the bone marrow because we didn't have enough space for them, and the end result becomes pancytopenia. So there are two different types. They're commonly classified according to the stem cell line that they come from. So they come from the lymphoid or myeloid cells. Remember, that's what we talked about. So whether it's the lymphoid cells or the myeloid cells, and we can classify it as acute or chronic in nature. Okay, so we have this wild proliferation of leukocytes inside of the bone marrow, which make it very difficult for all the cells to produce themselves. And so we end up with this pancytopenia and an inability to fight infection. So how does it manifest itself? It manifests itself as bleeding, bruising, and anemia. Of course, you can expect that. With anemia, we would expect fatigue and malaise. Bone pain, lots of times, is one of the first signs. Maybe even signs and symptoms of infection, being an infection itself, a persistent fever, night sweats, lymphadenopathy, so swollen lymph nodes. How does it get diagnosed? Bone marrow aspiration, bone marrow biopsy, CBC, a lumbar puncture, CT scan, and of course they are assessing the leukemic cells outside of the bone marrow. You know, they can see it. They can see it inside in the blood. They have spilled over. Acute myeloid leukemia, it is the most common, and it comes from the uncontrolled proliferation of the myoblasts. We remember that the myoblasts are the immature cells, and they make the red blood cells, white blood cells, and platelets. So we have this again, hyperplasia of the bone marrow, prognosis is poor. So when you hear leukemia, we're going to talk about it, but when you hear leukemia, you know that what it has to do is an inability to fight infection, and it's abnormal proliferation of the cells inside the bone marrow that spill into the general circulation. The onset is abrupt. They come in with infection and weakness. Like I said, prognosis is very variable, like how well the person does. Okay, how well the person does. With leukemia, lots of times we say, if you can survive the treatment, you can survive the disease. So we have these three kind of concepts that we go with: the induction, the consolidation, and the maintenance. In the induction phase, these people are usually hospitalized. What is the goal? The goal is to eradicate all the leukemic cells, and so eradicate all of the leukemic cells. That's very aggressive therapy. And associated with eradication of all of the leukemic cells, they eradicate all of the myeloid cells. In fact, an absolute neutrophil count of 0 is not uncommon. So I have written here, induce or bring a remission, aggressive treatment to kill leukemic cells. So when they kill the leukemic cells, they're also killing all of the other myeloid cells. So neutrophil count being low. These are the people we see on the neutropenic precautions. I say reach nadir. Reach nadir, you'll hear it, nadir point. That is the point when the blood cells are at their lowest count. These people are very sick and they cannot fight infection. So we eradicate all the cells. The idea is to put them into remission. And then we have that consolidation therapy, which the guideline there is once we get them in remission, we post-remission therapy, so we eradicate any residual cells that might be in there. So we reach the nadir, lowest possible amount, put them in remission, and then we give them another little dose, and then we move on and we give them some low dose every 3 or 4 weeks just to make sure that everything is under control. Acute lymphocytic leukemia, ALL. Okay, what is ALL? Again, it's uncontrolled proliferation of the lymphoblasts. They come from the lymphoid stem cells. 75, so these are the B cells and the T cells, right? So 75% of all ALL comes from B cell, abnormal proliferation of the B cells. 25% comes from abnormal proliferation of the T cells. It is a childhood, usually it's a childhood leukemia. It is more common in boys than it is in girls, and the peak onset is 4 years old. What do we see? We see lots of immature lymphocytes that proliferate in the bone marrow, and they impede the normal myeloid cells. So you have all these crazy B cell or T cell proliferation, and so then we don't have enough white blood cells, red blood cells, or platelets in there. So the leukocytes, either way, they could be very high or very low, but there's always a high proportion of them that are immature cells. Let's see. What else can I tell you? Leukemic cells, these leukemic cells often infiltrate other organs like the spleen or the liver, testes. So there's certain sites, and I'm not going to talk too much about this ALL, just a little bit. I believe that you'll cover it um, in PEDS. Okay, here was just a little chart for you to compare um, different sides. You see the AML is the myoblast and the hyperplasia of the bone marrow. The ALL is the lymphocytes, and it tends to be in children or older adults. You can have acute or chronic. In chronic, all right, let's talk about the chronic conditions that we might see in the CML and the CLL. Okay, so these are conditions that really primarily affect the elderly. Let's talk about the chronic myeloid. It is a mutation of the myeloid stem cell. So the normal myeloid cells are produced, but there's an there's an abnormal production of the blasts or the immature cells. So in the blood, you can have many different forms of the cell, from the blast all the way up through the mature neutrophil. It's not curable. It may be aggressive, or it may be slowly progressing. Then we have the chronic lymphoid leukemia. It's the most common form of leukemia in America. 81% of the people who have it are older than 60 years old. The life expectancy on average after diagnosis is about 10 years. Let's see what happens. So there is a clone, C-L-O-N-E, a clone of a malignant B cell, B lymphocyte, that somehow escapes apoptosis. Do you know that word? Apoptosis means programmed cell death. All cells live X amount of time, and it's kind of in their genetic makeup as to when they're going to die. So we have this genetic cloning of the B cells, and instead of dying when they normally would, these stay alive for a long time, which results in excess accumulation inside of the marrow and inside in the circulation. So these B lymphocytes are cloned, and they are produced, and we have an excessive circulation of the B cells. Malignant lymphoma of the Hodgkin's type. Okay, what is a lymphoma? Lymphoma is a neoplasm of the lymphoid tissue or the lymph system. It starts in the lymph nodes, and it can move to the spleen or the liver or the marrow. And there are two types of lymphoma: Hodgkin's lymphoma and non-Hodgkin's lymphoma. Here on this slide, we're thinking about Hodgkin's lymphoma. It usually starts with one lymph node. And then it will spread, it'll start in one lymph node, and usually in like the neck area, usually above the diaphragm. And then it'll spread along the lymph system node by node, kind of like progressively. That one node is usually painless. It usually has, all nodes it kind of feels firm or rubbery like. It's not hard. Hodgkin's lymphoma is something that's very treatable, and the goal through radiation and chemotherapy is to cure the person, and often, many times, we do cure the person, but we see an increase in the incidence of secondary malignancies, especially leukemia. So that means, like, You survived the treatment, you did well, but then a number of years down the road, other things develop, like particularly leukemia, some breast cancer is a common development. Infertility is a problem as well. Then we have non-Hodgkin's lymphoma. And non-Hodgkin's lymphoma is a non-localized neoplasm of the lymph system. So whereas Hodgkin's starts in one node, it's rubbery, and it's there, and it progresses along the lymph nodes, one to the next, to the next, to the next, kind of in a more patterned way. Non-Hodgkin's lymphoma is not localized. It spreads unpredictably, and it can have multiple sites. It usually has multiple sites. It is the sixth most common cause of cancer in the United States. It is very big and on the rise, and they don't really know why. So this neoplasm is usually, it can be a malignant neoplasm of the B cells or the T cells. I think the number is like 90% is B cells, and then maybe 10-15% of T cells. It can be slow, or it can be rapid moving. Now let's look at the nursing care of both types. Okay, so what are we going to do? Lots of times people are, because we have this abnormal proliferation of the lymphocytes is so that we have B cell and T cell aberrations. So we have infection as an issue. So a recurrent or an intermittent fever, night sweats, weight loss, malaise, and lethargy. And then these lymph nodes, usually in the cervical area, that present themselves, and itching. It's unexplained, but lots of people have itching. Non-tender nodes that are firm and movable. How do we diagnose it? All kinds of scans, checking out the bone marrow, remove the node and biopsy it, and the presence of certain types of cells. I won't test you on the Reed-Sternberg cells or anything like that. So, next we're talking about how do we treat it. We are treating it with combinations of chemotherapy and radiation. Excuse me, surgical removal of the lymph nodes for debulking. Radiation for debulking. And what about the nursing care? Well, nursing care is centered around, we're giving radiation and we're giving chemotherapy. So nursing care is centered around nutrition. Nursing care is centered around the prevention of infection and all of the things associated with myelosuppression. So when all the blood counts are low, we're concerned about patient safety. Let's talk about multiple myeloma. This is the last thing that we have to talk about today. I appreciate your time. Multiple myeloma. So what is a myeloma? Myeloma is a malignant disease of the plasma cells or the effector cells of the B lymphocytes. Let me say that again because that's a lot. So it is a malignant disorder of the B lymphocytes. And we remember with the B lymphocytes, when the B lymphocyte, when an antigen, whether a foreign protein, when an invader comes in, the B lymphocytes that have those little Y receptors on them are going and they are looking for any invader, and the B cells bump around, and finally the lock and key, the right combination for the antigen and the B cell, they make a connection. When they make that connection, the B cell is activated and it differentiates some into memory cells and some into effector cells or plasma cells. And then those plasma cells become antibody or immunoglobulin factories, and they produce the antibodies, and then the antibodies are released. So in this myeloma, what we have is a malignant disorder of the plasma cells or the effector cells or the antibody factories. So what we have is this gigantic abnormal production of a certain immunoglobulin, a certain antigen. The problem is that those antigens and immunoglobulins, they don't work. So they don't work properly. They don't function properly. So this specific antibody or immunoglobulin that's secreted, it can be detected in the blood or in the urine. And it often results in bone lesions because we have this abnormal proliferation in there. We end up with the bone lesions, which causes bone pain and causes the bones to break down. And when the bones are breaking down, so the long bones are breaking down, we have an increased release of calcium. From this bone destruction, we have lots more serum calcium, and that can cause hypercalcemia. And we'll remember that hypercalcemia can cause an increase in thirst, dehydration, constipation, confusion, general change in mental status. It could also lead to renal failure. But I say it's important that you know that that this abnormal proliferation of these B lymphocytes, the effector cells, the plasma cells, causes bone lesions because one of the early diagnostic signs is kind of like an unexplained back pain. So this unexplained back pain might be one of the first symptoms. In fact, an older adult who complains of back pain and has a total protein elevation should be evaluated for myeloma. Okay, so bone pain and fractures, anemia, renal dysfunction and fever, hypercalcemia, from the hypercalcemia, any of the neurologic symptoms. Positive Bence-Jones in the urine, what does that mean? That is, we said there are specific antibody chains that these effector cells, these plasma cells are making non-functioning antibodies, immunoglobulins, and they see those antibody chains in the urine, and they call that Bence-Jones. Lots and lots of plasma cells and the lytic lesions on X-ray. What are we going to do about it? There is no cure. So all we can try and do is control symptoms. And so what are they going to do? They're going to do chemotherapy in high doses of chemotherapy. We are going to give corticosteroids to decrease the number of cytokines. We see some of these very aggressive drugs that are listed there. I don't think that I'm positive. You will do some of these when in pharmacology, when you do the cancer lecture, but I will not test you on any of them. I will test you as in chemotherapy so that you know. You'll see on there thalidomide. Thalidomide is actually, I believe it's in the category drug classification as a sedative, but they were giving it for chemotherapy, nausea in chemotherapy, and they found that it had some anti-myeloma effects, so they do give it. But I point out thalidomide there because thalidomide, if you recall, is cannot be given to pregnant women because it has such significant birth defects, some physical changes. These people back in the late 60s and 70s, they were giving it to women for morning sickness, and it did help to control their morning sickness, but the children were born with little stumps for arms. Okay, So radiation, chemotherapy, taking out the spleen. Nursing interventions. Again, there's aggressive chemotherapy, um, aggressive chemotherapy. So we are watching these people for infection. We are watching and preventing um, them from losing weight. We are keeping them moving. We are trying to manage their bone pain, managing their bone pain. Um, Lots of times done with the biphosphonates, things like Fosamax is a biphosphonate, and nutrition, post-op management after the spleen is removed, post-op teaching, emotional support. You know that there is no cure for multiple myeloma. All we can do is try and prolong the death, basically. These are people who are often very good for interdisciplinary team consult. What does that mean? Uh, students who took students who've previously taken the NCLEX exam are saying that there was a lot of questions about who would need to have an interdisciplinary team. An interdisciplinary team is somebody who would have take advantage of many of the different disciplines in the hospital. Social work, nutrition, physical therapy, nursing, medicine. So lots of things. So you can imagine that keeping these people mobile and managing the bone pain, physical therapy might be in. Nutrition is a big thing. Medicine is in. Nursing is in. So that is a multi-interdisciplinary team. Our final topic today, bone marrow transplant, stem cell transplant. You'll see bone marrow transplants abbreviated in a chart, BMT. You will see stem cell transplant, peripheral stem cell transplant, PSCT. And it used to be that we could get stem cells from the bone marrow and we could get stem cells from the periphery. And so now we can get them from both places. And so you'll see both of those terms replaced with a newer term called hematopoietic stem cell transplant. So hematopoiesis, hematopoietic stem cell transplant. Okay, what is it? Well, we use it to treat multiple myelomas. We use it to treat the leukemias. What are we going to try to do? We're trying to cure the person. We are going to give chemotherapy in very, very, very high quantities, much higher than you could before we had stem cell transplant. And the goal is to give chemotherapy and eradicate all of the tumor cells, all the bad cancer cells in there. And it will clear all of the bone marrow of its components to prepare for this graft, so to speak. So you give very high doses of chemotherapy. It kills off all of the cells in there, all of the bad cells and all of the good cells. So we have the pancytopenia. That means all the cells are way, way down in there. And then after we take out all the cells, we reinstill the stem cells, and then we support the person while their hematopoietic system begins to work again. So here's how it works. We have to harvest the bone marrow. We have to harvest the stem cells, and it can be done in a couple different ways. It can be done through bone marrow aspiration, which is usually done in the iliac crest or in the sternum. It can be from the person themselves, or it can be from a specific match. And if you go on YouTube, you can actually see a bone marrow aspiration. It is painful. It does hurt the donor. After they are harvested through bone marrow aspiration, the donor may have some pain at the insertion at the donor site. So they'll usually it's usually done on a short procedure. It takes an hour or two to retrieve some. We can give some Tylenol or Advil for any kind of pain or discomfort. The donor will regenerate those cells in 2 or 3 weeks, 2 to 4 weeks. Um, we can also get stem cells from the peripheral blood. We can't collect them in as great a quantities as we can from bone marrow aspiration, but so it's usually done in multiple sittings. But it's kind of looks like it's like a separation machine. So the blood comes out like a dialysis machine. Dialysis machine. It comes out, circulates through, and it sucks out all the stem cells and puts the blood back in. So a person who has this multiple myeloma or has this terrible leukemia would go in and have some very high dose chemotherapy, and it would kill all the bone marrow cells, all the cancer cells, all the good cells. Then they wait. They wait 24 to 48 hours until all the chemo has cleared out of the person's body, because they can't because they don't want the chemo to hurt the new stem cells. And then they reinfuse in like 24 or 48 hours. They reinfuse the stem cells, and they say that that reinfusion is called the patient rescue, they say. And that's because the hematopoietic system was not working. It was very depleted. So they put them back in, and then in 2 to 4 weeks, the person will start making their own blood and blood products. In the meantime, in that 2 to 4 weeks, it is absolutely critical that this patient is prevented from getting infection. They are neutropenic precautions, and you are doing everything you can to keep. They do not have any immune system at that point, a neutrophil count of 0, and so they cannot get an infection because they don't have anything to fight it with. So we're working on that. We are supporting them with blood and blood products, because we got to keep the red blood cells and the platelets in adequate numbers to transport the oxygen and to keep them from bleeding. And of course, nutritional support is key here to success. And that wraps up our lesson today. Thank you.